Record. So Dr. Mangan, I'll let you begin.
Great. So thanks everybody for joining today. Today we're going to be talking about when to see a spine surgeon. And this talk is really geared for, uh, the pathologies that people develop that they may not know are coming from their back. So today we're going to define some commonly used terms for back and neck problems. We're going to talk about treatment overviews. We'll talk about a couple medical emergencies that come in when we talk about spinal issues. And then I'm happy to answer any questions at the end. So just a brief background on myself. I was born and raised in Delaware County, Pennsylvania. I graduated from the University of Scranton. I then went to the Geisinger Commonwealth School of Medicine. And then as Casey said, I did my residency at Jefferson with Rothman Orthopaedics. And then I was fortunate to go out to the Cleveland Clinic where I completed my spine surgery fellowship. And now I serve as an assistant professor at Jefferson. I operate in Delaware County at Riddle Memorial Hospital. I'm out in Chester County Hospital. I operate downtown at Jefferson, as well as Physicians Care Specialty Hospital, which is in Limerick. And I see patients in the Glen Mills, Bluebell, and Limerick offices. So to get into the presentation, so when to see a spine surgeon for your low back issues. So I always like to start out these talks by going through kind of the common phrases that people hear about their back and kind of try to describe what they are. So one of the things that people will commonly say is I have spinal stenosis. And so what is spinal stenosis? Spinal stenosis is the abnormal narrowing of the spinal canal. And so if we look at an MRI, which is on the screen here, I've outlined the spinal canal in red. And within that red tube is where our nerves are. The spinal cord ends at the top of our low back, which is up at the red arrow. Sorry, it's advancing on its own. And the nerves, your spinal nerves, come down off of the tip of the spinal cord and they go down to the bottom. So spinal stenosis is when we have degenerative changes or wear and tear within the spine. It can be from a disc herniation. Some people are born with a smaller canal than others. And arthritis that forms, which ends up pinching the nerve and causing that bottleneck. And you can see at the bottom of the screen here, there's a bottlenecking that happens. And you can see, sorry, I don't know why this is advancing, that is pinching all those nerves together. And we'll talk about what the signs and symptoms are of spinal stenosis that that result from this kind of pinching of the spinal canal. So people who have lumbar stenosis will commonly present with difficulty walking. They'll feel like they're bent forward, or their family members will say, you're walking kind of hunched over. They will frequently have pain down the back of their legs or in their buttocks. A lot of people will have buttock pain. That is kind of one of the more common reasons that people will come see us. And people will feel like their pain is worse when they stand up straight. Frequently, patients will come in and say, I can walk about 20 yards and then I have to sit down. If I sit down, all of my pain goes away. But while I'm standing up and I'm walking, I really have a difficult time and my legs feel heavy and it's hard to walk. So more symptoms, as we said, you can have pain down your legs. You can have numbness and tingling. Some people will have weakness or cramping in the legs. And we call this myriad of symptoms neurogenic claudication. Neurogenic claudication is the technical phrase for spinal stenosis. And it's the symptoms that you get from the pinching of the nerves. And this is that buttock pain that I was talking about. Patients will say that they have pain down their hamstrings or in the back of their legs, heaviness in the legs. People will often say, I feel like I'm dragging sandbags. My legs just feel like they have no power. And they'll have a difficult time walking distances. And again, it usually gets better when they sit down. If you look at the pictures on the right of the screen here, the picture on the far right is, I call this the deli slicer view. This is the axial view of the spine. And so in this picture, we're looking kind of down the tube of the spine. And you can see in all those arrows, that's a disc bulge and it's arthritis that is pushing on the spinal canal contents, which is the kind of the light gray area in the middle. That's all the nerves. And they should look like a big circle with a bunch of dots in it, but you can see it's getting kind of compressed from all sides here. So that tube is getting squeezed. And that's what really gives patients their symptoms. This is one of the classic signs of somebody who has spinal stenosis, and this is called the shopping cart sign. So frequently patients will say, I can't walk a long distance. I can't, walk down the block because my legs just feel so heavy and I have so much pain. And then I'll ask them if they can go to the grocery store and make it through the store. And most people with spinal stenosis will say, if I hold the cart, I can't walk all that long, but I can walk much better if I'm leaning on the cart and I can make it through the store and get everything I need. And what happens is when we lean forward, we stretch out some of that arthritis and the ligaments that form in the back of our spine, which makes more room for those nerves temporarily when we're in this bent forward position. And so they actually do feel better, patients, when they lean forward. And when we extend our back and we try to stand more upright, we actually close down that space a little bit more. And so symptoms tend to get worse with extension. One of the causes of spinal stenosis is instability. So instability is an abnormal alignment of the lumbar spine. We call this a spondylolisthesis. And this is when one vertebrae shifts forward on the other, and it causes a bottleneck or a pinching of the nerves at that level. Here I've drawn the outline of the back of the L4 vertebral body, which is the top line, and the L5 vertebral body, which is the bottom line. And you can see how they don't line up. But if you drew that same line above L4, all of those vertebral bodies would be in a line. And what happens is this is that as arthritis that has caused the L4 vertebral body to shift forward. And that shifting forward actually makes the canal smaller at that area and makes patients more prone to developing spinal stenosis. So when is it time to see a spine surgeon? So, we always try to treat things conservatively. And obviously, if this is the first time you're having these issues, conservative treatment is always how we start, with the exception of patients who develop weakness in their legs. Weakness is something that does not necessarily always get better with conservative treatment. Sometimes it can, but most of the time weakness gets us concerned for neurologic progressive injury. But patients who have walking impairment, patients who feel like they can't stand for very long, and their pain is just persistent, it's diminishing their quality of life, it's time to at least get a surgical evaluation or a spine evaluation to try to figure out what's going on and what's causing it. There's a lot of different causes of spinal stenosis, and try to figure out what the best treatment strategy is. And we'll get into the surgical treatment strategies in just a few minutes. The next thing that we'll talk about is radiculopathy. So most people don't know what the word radiculopathy is, but they do know what the word sciatica is. So sciatica is a pinched nerve in your low back, or radiculopathy, and it's pain that follows kind of the path of the nerve down the leg or down an arm, in the neck. And it can be associated with back pain, particularly if it's caused by a herniated disc or arthritis or degenerative changes. Patients can have back pain and this associated leg pain. Typically, it's unilateral. Sometimes it's bilateral. And it causes a significant amount of distress for patients. And so that's a common reason that people see us. So this is just a schematic to show the most common ways or common distributions of pain that people get in the leg. So patients will feel that they have pain in the back of their buttock or their thigh, in the back of their calf, and then to the bottom of their foot to their small toe. And that's usually indicative of an S1 radiculopathy, which is the very bottom nerve in our low back. The L5 nerve goes down the side of the leg and can go to the big toe. The L4 nerve, people will feel, goes across the front of their thigh to their knee and then down the anterior aspect of their shin. And then the L3 nerve can go across the anterior thigh and can give people pretty significant thigh pain or groin pain as well. And so, the symptoms, as we've mentioned, are pain down the leg, and they follow the path of the nerve. So when we are evaluating for patients with radiculopathy, we're trying to make sure that a patient's pain pattern matches up with their imaging. And patients will often have numbness or tingling in this distribution. And if the nerve is irritated enough, they can develop weakness in those muscle groups that nerve innervates. One of the causes that people also often hear is a herniated disc. So a herniated disc, if we think about what the discs are in our low back, they're the shock absorbers of the spine, and they look like a jelly donut. And so they're kind of firm on the outside, and they have a jelly-like material on the inside. We call that the nucleus pulposus. And so what can happen is over time or acutely, patients can develop a small hole or a rent in the outer aspect of the donut. And some of that jelly can squirt out and get pushed out into the spinal canal or the neural foramen. The neural foramen is the little tunnels off to the side of the spine. Sorry, I don't know why this keeps changing, where the nerve exits the spine. And so sometimes it will cause spinal stenosis type symptoms because it's in the middle of the canal. Otherwise, it will just get a single nerve or two nerves if it gets them off to the side of the spinal canal or into the neural foramen. The material itself, that jelly, is extremely irritative to the surrounding tissues. So often when this happens, patients have a huge flare-up of pain. It's very uncomfortable. But it also, besides being irritative, it can cause mechanical stress on the nerve, which can lead to weakness and other problems. And so when to see a surgeon if you have a herniated disc or you have a cervical or a lumbar radiculopathy, excuse me, is if the pain is persistent and it's causing limitation. Typically, luckily, a herniated disc will self-resolve itself over the course of somewhere between 6 and 12 weeks. However, if it's still persisting and it's not getting better, there can be things that are done with it to treat it, including injections, medications, and then obviously lastly surgery. But patients who develop weakness in the leg, acute weakness that's not resolving, it's time to see a surgeon just to have that evaluated to make sure that you identify why you're weak and what's causing it. So treatment options for lumbar pathology. So the goal of lumbar spine surgery in general is to make more room for the nerves. So we do that most commonly by doing what's called a lumbar laminectomy. So that's when we remove the ligament and the bone in the back of the spine. And quite frankly, we scrape the arthritis off of the back of the ligament, off the back of the nerves to make more room for them and take the pressure off of them. Some patients have instability, like we talked about earlier, in form of a spondylolisthesis, or they've had such bad disc collapse that they have bone encroachment on the nerves. And in those patients, sometimes we'll do a lumbar fusion to stabilize that area or to make more room in the nerve tunnels that we can't do with a laminectomy alone. And lastly, there's something called a microdiscectomy, which is when we go in there and we just remove a small piece of bone, a small piece of ligament, and we can remove a disc herniation through a small incision to take that pressure off the nerve and hopefully relieve the pain that's going down somebody's leg. So this is a picture of a lumbar fusion. This is the rods and screws in the back of the vertebra. And this is for a patient who has instability. If you look at the preoperative x-ray, which is on the left-hand side, the one closest to the words on your screen, you can see that at the L4-5 levels, those bones don't line up as they should. And so after surgery with the lumbar fusion, everything is back in alignment and their pain is much better treated. Here's just a schematic of the microdiscectomy. On the top of the picture on the right, you can see that there's that hole in the outer aspect of the donut, and some of that jelly has squirted out and it's pushing on that nerve root. And so what we do in those situations is we remove a small part of the bone and the ligament above that nerve root. We move the nerve root out of the way, and we're able to take away that disc herniation and take the pressure off the nerve. And that's usually done as an outpatient surgery. So let's move on. We'll talk about neck issues next. So just as we started in the lumbar spine, we're going to talk about stenosis in the cervical spine. So in the picture on the right, again, I've outlined the spinal canal in red. The spinal cord is that dark cord-looking structure in the middle of the red. The white area around the cord is spinal fluid. And so if we look at this picture, you can see multiple areas where the red lines are almost touching because the spinal canal is getting narrowed from disc herniations and pain. Disc herniations and arthritis. And so we get a different set of symptoms and a different condition when we have narrowing of the spinal canal within the neck itself. So this is called cervical myelopathy, and it's a clinical syndrome that occurs when patients have chronic progressive compression of the spinal cord within the neck or the chest. The spinal cord dysfunction that occurs is due to longstanding stenosis. It can be acute in some instances. If somebody has a very large disc herniation in the neck, they can present with symptoms of cervical myelopathy. And this tends to be a progressive disease that gets worse over time, and we'll talk about what those symptoms are. This is the most common cause of spinal cord dysfunction in adults. So this is one of those things that we probably see it in the people that live around us and the people we interact with. And it has a prevalence of about 2% of the total population. It's more common in women than men. It typically starts to occur or become symptomatic in patients in their 50s. And it's often painless. About 30% of patients will not have any pain associated with these symptoms, which are caused by a pinched spinal cord in the neck. And that's what makes it hard to diagnose and why it largely goes unrecognized in many people until it's progressed. So what are the signs and symptoms to look out for and that you should be concerned with if you have them? So the initial symptoms people will start with is they have what we call non-dermatomal numbness that starts in the fingertips. And what that means is that people develop symptoms that are in their hands that don't necessarily follow a single nerve root. So we talked about sciatica in the neck. or sciatica in the low back. Sciatica in the neck is called, again, radiculopathy, and that's usually when patients get numbness that goes into certain fingers. This is more that all your fingertips feel like they're numb and tingly. Some people describe that they feel like they have sand on the tips of their fingers, and then patients will report that they have loss of manual dexterity. So I have difficulty buttoning shirts. I can't use zippers anymore. Patients will often start wearing sweatpants or other sweaters that they don't have to worry about buttons because they have difficulty performing those tasks. And patients will say that they're dropping objects, or they'll notice that it's harder to write with a pen and pencil, and that they have difficulty with handwriting changes. As myelopathy progresses, patients will develop discoordination of their gait. And so patients will feel like their balance is off and they'll have a fear of falling. Uh, this is something that can be kind of mild all the way to people being in a wheelchair if it's extremely progressive. Patients will feel like when I open a doorknob, I feel like I'm going to fall over from walking on flat ground. I just don't feel steady. And this is a concerning symptom of somebody who's having moderate to severe cervical myelopathy. So in severe myelopathy, when this has been progressive, patients can present with profound gait disturbance or hand dysfunction. Their hands really aren't working. They have trouble walking. Oftentimes, these patients will come in with an ambulatory assistive device, right? So I've started using a cane or a walker because I feel so off balance. Some patients in really severe circumstances can develop bowel and bladder retention or incontinence. And if this progresses long enough and it's untreated and unrecognized, patients can have the clinical picture of having a spinal cord injury or even in rare instances, quadriplegia, tetraplegia. So if you have concerns for cervical myelopathy, if you have any of these symptoms, I think it's always a good idea to be evaluated. Even if it ends up not being the neck, it's an important thing to get evaluated to make sure that you don't have spinal cord compression in the neck, because myelopathy is a progressive disease. What we know is that patients who have this and are developing it, they don't tend to get better with conservative treatment. They don't tend to always get better after surgery, either if their symptoms have been going on for too long or are too severe. So getting screened and evaluated earlier rather than later is better. Surgery is good and effective at preventing progression of cervical myelopathy. But sometimes, patients fail to progress or improve in a significant way after surgery if it's really long-standing or very severe when they come in. So we try to have patients get screened and evaluated earlier rather than later. And this is one of the main reasons I think people should see a spine surgeon, is because this is more common than people realize. Next, we'll go on to cervical radiculopathy. So like we talked about sciatica in the leg, this is sciatica of the arm. And again, this is a pinched nerve in the neck that will follow a patient's dermatome, or the area where the nerve goes down the arm. Patients can have neck pain associated with the onset of radiculopathy. And this is commonly caused by arthritis and degenerative disc disease, as well as disc herniations within the neck. You can see on the picture on the right, this is a view of the cervical spine. And here, again, we have that jelly donut with some of the jelly squirting out that's pushing on that nerve root and causing pain down the arm. So the symptoms of cervical radiculopathy are similar to that in the lumbar spine. So patients will have weakness, or they will commonly present with numbness and tingling in their arm. They can have pain, obviously, in the arm, and neck pain is more common in this cervical radiculopathy. About 80% of patients will have some component of neck pain as well. Patients will come in and say that if I hold my arm over my head, or if I lay down and put my arm over my head, that my pain is better, and that's a tolerable position. We call that a cervical release, and that is a sign that you're able to shorten the nerve and take tension off of it, and it usually improves symptoms. So what are the treatments for conditions of the neck? So the goal, again, of surgery is to make more room, if we're talking about cervical myelopathy, for the spinal cord. We can do that from anterior-based surgeries, where we go in through the front of the neck and take pressure off of the spinal cord by removing disc herniations and disc bulges and bone spurs. Or in certain circumstances, depending on the patient's pathology, we do what's called posterior-based surgery, where, again, the gold standard is a laminectomy, where we remove the bone from the back of the spine and the ligament that's pushing on the spinal cord, and we perform a fusion. There's another procedure, which I'll show a picture of in a second, that's called a laminoplasty. and that is another good option for certain patients. We'll get into that in more detail. So this is a picture of what an anterior cervical discectomy and fusion looks like, or an ACDF is commonly referred to. This is when we take out the disc from the front. We will remove the disc herniation and bone spurs from the back of the spinal canal. We replace the disc with a piece of bone or a cage that's made of either metal or plastic that's specially designed for this area. And then usually it is fastened with a plate and screws on the front to aid and improve the fusion in this area. We can do this at one level or multiple levels, depending on the patient's pathology. And this is a very effective way of treating cervical radiculopathy and myelopathy. This is a schematic of a posterior cervical decompression. So this is somebody who has multi-level disease, or they have a contraindication from going into the front of the neck. And you can see in this picture here that we're looking at the back of somebody's head. In the top of the picture, the spinal canal is in the middle, and that's the gray area where the laminectomy has been performed. That's where we've removed the bone and the ligament. And then there's metal rods on the side and screws which are placed to keep the bones in the proper alignment after surgery. And this is a very effective way of taking pressure off of the spinal cord and helping prevent the progression of myelopathy. And then the last treatment option in the cervical spine is something called a laminoplasty. This is a great procedure where we're able to make more room within the spinal canal by opening up the bone like a hinge. So we open it up like a hinge and a door, and we put in a little spacer to keep the door open, so to speak. And you can see the picture of this on the screen here. And we've cut the bone in a way that we've been able to put the spacer in, and we increase the surface area and the volume within the spinal canal for the spinal cord. And this is a really nice procedure for patients who have cervical myelopathy or spinal stenosis and have good overall alignment, that we can perform this procedure. And this is a motion sparing procedure. So this is not a fusion, although there is implants put in. This allows patients to keep the range of motion in their neck and treat their myelopathy very well. So the last thing I wanted to touch on is surgical emergencies and urgencies, things to think about and look out for. So one of the things that we treat as spine surgeons, which is a surgical emergency, is something called cauda equina syndrome. And so what this is compression of all the nerve roots in the lumbar spine. So somebody has either severe stenosis that acutely progresses, or they have a large disc herniation that really compresses all of the nerve roots in their low back. And we call that collection of nerve roots the cauda equina. And so patients will present with leg weakness, numbness, tingling in their legs, and they'll have bowel and bladder incontinence. So, their patients are urinating or having bowel movements that they didn't know, and they'll have saddle anesthesia. So this is numbness and tingling in the groin, or numbness and tingling where you wipe, is how some people will describe it. And this is something that if you develop this is, go to the nearest emergency room. This is a surgical emergency. It needs to be evaluated. And the treatments for this are similar to what we discussed with the lumbar spine. Depending on the cause, it's a decompression through a laminectomy alone. If a fusion is necessary, then a fusion. Sometimes a microdiscectomy, depending on what the pathology is that's causing it. But this is something that we want everybody to be aware of, the signs and symptoms of this, because the longer this is present, the lower the likelihood is that things will resolve. And just one other urgency to talk about is a spinal infection. So this is patients who develop new pain in their legs, weakness, anything that is progressive, should be evaluated. Patients can develop spinal infections, which can be in the disc space. So on the right here, you can see at the bottom of the picture, in between the L4 and the L5 bone, it looks darker, it looks irritated. And patients can develop, we call discitis, or an infection within the disc space, or patients can have what's called an epidural abscess, which is an infection within the spinal canal. If this is untreated or progresses, it can lead to a neurologic injury and progressive weakness. So if you have signs and symptoms concerning for infection and you're getting weakness in a limb or new numbness and tingling, you should be evaluated for concern for an infection in the back itself. So that's the brief
questions. Never hesitate.
That's the brief conversation. If anybody has any questions, I'm happy to answer them now.
Thank you, Dr. Mangan. Great information. Everyone, if you can see the Q&A dialogue dialog box at the bottom of your screen. If you have any questions, you can type them in. We'll try and get to one or two before he has to go start with patients. But if not, then we thank you for joining. And again, I did record this, so we will send this out if you need to reference back or share it with a friend. I will remind you, if you do need to make an appointment, we encourage you to use the phone number 610-480-6584. Again, 610-480-6584. I do have a question, Dr. Mangan. Can spinal stenosis cause muscle tightness?
That's a good question. And so, spinal stenosis can cause back pain in certain circumstances. We call it it's atypical claudicatory symptoms. So some patients who have really severe spinal stenosis, they will have difficulty extending, and they can have a significant amount of back pain with that. I think of that can cause spasm in the back, or muscle tightness. But it's a reason to be evaluated. One doesn't always result in the other, but if you're having concerns with that and some of the other issues of spinal stenosis, it's definitely worth getting evaluated and checked out. And then I can see here what specialty addresses paraspinal issues. So paraspinal issues, typically we will have our physiatry team evaluate initially. If they progress or patients develop radiculopathy, then they'll send them over to the surgeons. They're really the experts at treating paraspinal muscle issues and back pain issues itself. Ablations within the spine are one of the treatments that our non-operative physicians perform. And an ablation is when they go in and they try to numb the nerves that innervate the facet joints. And the facet joints are the bones in the back of the spine that develop arthritis, like our knees and our hips and our elbows. And what the goal of the ablation is to take our ability to sense that joint away. And typically, if patients are having pain from arthritis within that joint itself, an ablation is a very effective treatment. The nerve can grow back, so it's not necessarily always a permanent treatment, but patients can get good relief from it. And that's typically a reason patients have just back pain, not leg pain, is because they can have, isolated arthritis within the back that luckily is impinging the nerves or causing neurologic symptoms. And that's best treated by one of our physiatrists.
Great, thanks. My pain is not in leg, only back. What does that indicate?
So, it's a good question. Pain in the back itself can really be multifactorial. There's a lot of causes of isolated back pain. It can be arthritis, like we were just talking about in the facet joints. It can be muscular. It can be there can be non-spinal causes of it. And so, typically what we have patients do is set up an appointment with one of our physiatrists to see if they have any causes of back pain that are treatable, like facet arthritis, or there's new procedures that they can do for patients who have pain that's generated from the vertebral body or the disc. And those treatments are best treated by our physiatrists.
Thank you. There are some questions that are coming in that are too specific. We're not going to be able to cover. So I'm just letting you know that now, right now, only general questions. Do you use newer electronic tool to grind off the arthritis rather than one that is like a Dremel tool?
So there's certain ultrasonic technologies that you can use that we do have access to take away the arthritis. And so we use whatever is the most appropriate for each patient. We do have access. I regularly use CT navigation for my lumbar fusions, which is an effective way of placing instrumentation and allows us to do it with accuracy and confirm everything is exactly where it should be before patients leave the operating room.
Thank you. Also, I do want to make note, we do have another lecture tomorrow on low back pain. So there are some of these, there may be some questions that might get answered in that if anyone is interested, if you don't get your, if your question doesn't get answered. Um, let's see. Are you,
So I can see, what is the role of epidurals in treating leg pain? So epidurals, the goal of the epidural is to take down inflammation or the irritation within the nerve root itself from the injection. And so they can be a very effective way of treating um, acute leg pain or even chronic leg pain. Sometimes we'll use epidural injections as a confirmatory test, to make sure in somebody who's had longstanding pain that we're treating the right area. So I use them both in a diagnostic and a therapeutic way. There is, looking at one of the other questions here, I do think that there is a limit on the number of shots that patients can get. Typically, our physicians will limit them to 3 to 4 a year because we don't want to give patients too much steroids. Um, and so they're effective. I certainly use them in my clinical practice quite frequently. And I think that they're a very effective way of treating patients conservatively. And if they fail that in the long term, it can be a very effective uh, diagnostic tool.
great, thank you. Is physical therapy or exercise an option for pain down the leg?
Yes, I think, when we talk about conservative treatments, physical therapy and anti-inflammatory medicines are kind of the first line treatment of treating lumbar radiculopathy or the pain down the leg. And so that is, it's a great way to start. As we talked about, patients who have kind of acute pain onset in their leg will typically get better over that course of 6 to 12 weeks. So if we can do exercises and therapy to keep patients moving during that time, it can be a very effective way of treating pain in the legs.
Are there non-surgical techniques? We did just talk about physical therapy. Again, there is a non-surgical spine lecture tomorrow at noon as well. So if anyone is interested, you have my email address, or you can go on our website and sign up for that as well. That might touch on some of these questions. So the last one is do you have a quick blurb on awake laminectomy?
So people are doing them. I don't know anybody in our area that does an awake laminectomy. Typically, this is something that patients are asleep for, depending on the size of the laminectomy or what's going on. Some of those procedures are same day in and out procedures, and they can be effective. Very effective and kind of, you know, uh, minimally invasive. But I don't know anybody around here who's doing them, but certainly there's places in the country where they're doing awake
Okay, great.
laminectomies.
And then too personal, but about appointments. If you are going to get injections, that doctor at Rothman will just let them know if you are interested in seeing Dr. Mangan. But I would
Yeah, typically they'll if they, I'm happy to see the patient, or typically they'll see the patient for the doctor for the injection, and then if it works or doesn't work, I'm always happy to see them. We can kind of evaluate what to do either with the improvement or with the lack of improvement.
right. All right. Well, Dr. Mangan, I appreciate you taking the time. Everybody who is on here, thank you so much for joining us. I will send this recording out in the next couple days.
Thank you, everybody. I appreciate it.
Thank you. Have a great day. Take care.